So the first thing we're going to talk about is we're going to review the epidemiology of atrial fibrillation, and you'll see it termed AF in this presentation. And epidemiology is just the prevalence, how common is it, who ends up with it. And we'll describe the pathophysiology, why atrial fibrillation happens and how it happens in the heart. And we'll also be discussing the complications and symptoms of atrial fibrillation. We'll compare the treatment strategies, and there's really two main strategies for atrial fibrillation. It's rate control or rhythm control, or sometimes a mix of both. And we'll talk about the benefits and differences between those. And we'll also briefly talk about warfarin, the old and the new anticoagulants, and Dr. Goldhaber did a great job of covering this already, so I'm just going to touch up on it at the end. Now, atrial fibrillation is extremely common. It's actually the most prevalent sustained cardiac rhythm disorder. So if you end up in the hospital with an abnormal rhythm, there's probably a better than a 34% chance that is atrial fibrillation. That's how common it is. And up to about 1/3 of all hospitalizations for cardiac arrhythmias are from atrial fibrillation. And it affects more than 3 million patients or people in the United States right now. And that number is certainly going to change over the years, and this is probably because of the aging population. They project that by 2050, this number will double to more than 6 million people in the United States. And you are more likely to have atrial fibrillation if you're a male than a female. And it's not really understood well, but you can see across the different age groups, there's more males with atrial fibrillation than females. And you can see how sharply the incidence of atrial fibrillation goes up across the age groups. So if you're less than 55, for example, there's a very, very small chance that you'd have atrial fibrillation. And it's usually related to structural disease. And if you're over 80 and you're a male, there's a 10% chance that you have atrial fibrillation. I think that's an astronomical number. And the first thing we'll do is we'll really break down atrial fibrillation for you. What does it mean? What is it? And we'll talk about the first word in there first, atrial, and it refers to the atrium. And there's 4 chambers of the heart, and the atrium are the top 2 chambers. This is where the blood comes into your heart. The bottom 2 chambers are your ventricles, and that's where the blood's pumped out of your heart. So fibrillation refers to the rapid, irregular twitching of the top 2 chambers, atrial fibrillation. And what this results in, and it results in a rapid ventricular rate. So the ventricular rate is the bottom of the heart, and it's rapid and irregular, and you can tell by your pulse a lot of times whether or not you're in atrial fibrillation or your heart rate. And there's no repetitive pattern to this abnormal rhythm, okay? So it's been labeled the only cardiac rhythm that has an irregular pattern, and it has a irregular rhythm, and there's no pattern to this irregular rhythm. So it's called an irregularly irregular rhythm. Now, to really understand atrial fibrillation, we have to talk about the normal heartbeat or the normal heart rhythm. And the normal heart rhythm is actually initiated by the sinoatrial node or the SA node. It's our natural pacemaker. It's located right in the top right atrium. And that initiates your heartbeat. And we can actually track the electrical activity in your heart using an electrocardiogram or ECG. A lot of you guys have probably been hooked up to these ECGs. You can see the example on the bottom left of the slide. And I've highlighted the P wave, the first part of the electrocardiogram. And the P wave represents this SA node initiating an electrical impulse. The electrical impulse spreads from the right atrium to the left atrium. And that's how your heartbeat is coordinated through electrical activity in your heart. Once the SA node fires an electrical charge, it moves to the right atrium to the left atrium, and then it moves down to the ventricles. And this has to be a very powerful electrical charge because we need to contract the ventricles with this charge and and we need to send the blood throughout your entire body. So you see this big QRS complex that's highlighted in the echocardiogram. That's the next part of the heartbeat. This is when your heart contracts and pumps the blood throughout your body. And the atrium, with atrial fibrillation, is not getting that charge from your pacemaker only. It's just getting charges from all over your atrium. So these little focal points of electricity that are all over your heart and trying to initiate a heartbeat, and not just your natural pacemaker. So instead of seeing a nice clean P wave, we see this almost scribble mark in between the QRS complexes, and that's really the abnormal electrical charges with atrial fibrillation. And you can see the difference between the echocardiograms. We have a nice clean P wave in the first one, where your natural pacemaker is starting the beat, and in the second one there's no recognizable P wave. The electrical impulse is coming from all over your atrium. And there's no pattern. You can't predict what's going to happen next with these electrocardiograms like you can when you're in normal rhythm. So there might be a big space between one heartbeat and a very small one between the next. And that's really how it's diagnosed. You can go into your primary care doctor's office, and they can listen to your pulse or listen to your heart and know that you're in an irregular rhythm. But when they go to diagnose you, the gold standard is really the echocardiogram. And there's three main classifications to atrial fibrillation, and when you're trying to remember them, think about the 3 Ps. The first one is paroxysmal atrial fibrillation, and this is when the episodes terminate spontaneously on their own, and it lasts between probably 24 hours and 7 days. If it goes longer than 7 days, then we call it persistent atrial fibrillation, which fails to terminate within 7 days. And if it goes even longer than that, then we'll call it permanent atrial fibrillation, which is also sometimes a treatment decision. If you're in permanent or persistent atrial fibrillation and we can change you into normal rhythm, then that would be called persistent atrial fibrillation. But if we choose not to try to get you into normal sinus rhythm, we choose to use a different treatment strategy, then we're saying we're leaving you in permanent AFib. And sometimes the difference between those two is just the way we treat you. Now, there are a few major consequences of atrial fibrillation. The first one that I want to talk about is the loss of organized atrial contraction. So instead of this organized heartbeat from the atrium, we're getting a very unorganized one, or small twitching. You lose your atrial kick, which means your atrium doesn't contract as hard and as strong as it usually does. And what that can lead to is exercise intolerance, or even acute heart failure, which is, can be reversible with treatment. Now, the other consequence is rapid ventricular rate. This is a rapid heartbeat. Remember, when your ventricles contract, it gives you a heartbeat. Where the atrials contract, it's just trying to push the blood into the bottom of the heart. So you can't tell by your pulse when the atrium contracts. You can only tell when the ventricles contract, when it pumps it to the rest of your body. And sometimes the atrium can beat with atrial fibrillation 3 or 4 times before your ventricles ever contract. It's supposed to be a 1-to-1 ratio, and it's supposed to be very coordinated, but with atrial fibrillation, it's not so coordinated. And with rapid ventricular rate, we can get angina, which is chest pain, okay? That's because the heart's working very hard, and it's not getting as much oxygen, and when it happens, we feel chest pain. And there's also what we can get is something called cardiomyopathy, which is thickening of the heart muscle. Just like any other muscle in your body, when you work it very hard, it gets bigger. But with your heart, this is a bad thing because it's becoming more stiff. Also, we want your heart to be very pliable, very flexible, so it can really push all the blood out that it needs. So a thickening of the heart muscle is actually a bad thing with this particular muscle. And it thickens with almost like scar tissue instead of regular muscle. So the conduction or the electrical energy cannot pass through the scar tissue, and it usually evolves into worse atrial fibrillation. So a lot of times you'll start as paroxysmal AFib, where it goes in and out of atrial fibrillation, then it will move to persistent AFib, and then after a while you'll be in permanent AFib. It's usually a progressive disease. Now, the most serious probably consequence of atrial fibrillation is the left atrial thrombus. Okay, when you're not squeezing all that blood out of your atrium and it's kind of sitting around, blood's supposed to be moving at all times in your body, and when it's not, it tends to want to form a clot, and it usually forms in the atrium, in the appendages of the atrium. And if a little piece of that clot breaks off, or if the entire clot breaks off, the most common place for it to go is to your brain, cut off the blood supply to a part of your brain and cause a stroke. Or a mini stroke is one that resolves within 24 hours. And it can also cause what we call systemic embolism, where the blood clot doesn't go to your brain and stops somewhere else in your body, which is much less common. So let's talk about some of the different treatments and treatment goals. There's, like I said, two real ways to treat atrial fibrillation. And they both have the same goals, is to alleviate symptoms. With rate control, if we choose to use rate control, then we're leaving your heart in atrial fibrillation and we're just controlling your rate. We're slowing down the rate so your heart's more efficient and it's beating stronger with each beat. And that would be rate control, where we're actually looking for a resting heart rate for less than about 80 beats per minute. If we were to put a heart monitor on you to look at your heart rate and your electrocardiogram through 24 hours, we want that beat to be less than, the average to be less than 100 beats per minute. And we can even tell with moderate exercise, we want your heart rate to be less than about 110 beats per minute. With rhythm control, we have a slightly different strategy. We're actually trying to restore normal sinus rhythm when we treat with rhythm control. Or we're trying to limit the amount of time your heart stays in atrial fibrillation. We're trying to prevent the amount of times it goes into atrial fibrillation. And that's the idea behind rhythm control. Now, whether we choose rate control or rhythm control strategies, we need to make sure that we choose anticoagulation always. So it's rate control or rhythm control plus anticoagulation to prevent the stroke or systemic embolism. So we'll go over some of the approaches to rhythm and rate control. And rhythm control can be done a few different ways. We can do it with a direct current cardioversion. This is where we actually directly shock your heart. And the idea is similar to like a computer. If your computer's not working very well, we shut it down and we reboot it. And that's what this electrical shock does. It kind of stops the heart, lets it reboot, and then hopefully it will start working properly in normal sinus rhythm. We can also use different type of medications for rhythm control. These are your antiarrhythmics, the ones that change your rhythm from atrial fibrillation to normal sinus rhythm. And we can use a couple different types of procedures. A maze procedure is actually open heart surgery. And what they do is they make little incisions in your heart, then stitch it back up. And what these incisions do is it kind of corrals the abnormal electrical activity. It boxes it in so that it doesn't spread to the rest of your heart and create an abnormal beat. And all that will be left is your normal electrical pathway, and hence your rhythm will go back into normal sinus rhythm. That's the hope anyway. And the ablation is the same theory, but instead of making little incisions, they can go through a blood vessel in your groin, almost like they're doing a heart catheterization, and they can go up with a radio frequency catheter, and they burn the little areas that are causing the abnormal heartbeat, and just leaving, again, the normal pathway, and hopefully they'll go back into normal sinus rhythm. With rate control, it's a little bit different. We mainly use pharmacological agents. We use medications for rate control. Okay, these are like your beta blockers, like metoprolol, toprolol, or carvedilol, and your calcium channel blockers, diltiazem and verapamil are the main ones there. And they just slow your heart down so that you're not getting the symptoms of atrial fibrillation. And we can also use surgery for rate control, but it's very rare. Basically, we will wipe out anything that is causing a heartbeat to initiate in your heart, and then we'll put in our own artificial pacemaker to make our own rate. Now, for years and years and years, it was always, should we treat a patient with atrial fibrillation with rate control or with rhythm control? Which one's better? And I think finally we got our answer in the early 2000s with the AFFIRM trial. And what the AFFIRM trial showed is that both treatments are very similar to each other. One's not better than the other. One's not significantly better than the other. We always thought that rhythm control would be better. It would be a lot nicer to change your rhythm than just to control it in atrial fibrillation. But here we actually found out that rate control is a little bit trended to be a little bit better than rhythm control as far as how sick patients got or how long they lived. And the only significant difference between the rate control group and the rhythm control group is that the rhythm control group spent more time in the hospital than the rate control group. They were in the hospital more often. And the reason for this is most likely because the antiarrhythmics that they use for rhythm control usually have some nasty side effects, and they have to be adjusted a lot. So that's why these patients were going into the hospital more often. So now that we have this data, we use kind of like a stepwise approach to treating atrial fibrillation. First, we'll treat the initial symptoms, and if there is a reason why you got atrial fibrillation, there's a few different reasons that can cause, a few different things that can cause atrial fibrillation. One of them could be like high blood pressure or thyroid disease. That would be the first thing we treat before we try to fix your atrial fibrillation. If that's causing it, we're going to fix that first, and then we're going to treat your atrial fibrillation if it persists. And once we do that, the first thing we really want to do is add anticoagulation, okay? That's important. We want to make sure we protect you against a stroke. And a lot of times, and it's patient to patient, but a lot of times the third step, what we'll reach for is rate control. It doesn't have, the drugs a lot of times don't have as bad of side effects, and we know that it's just as good as rhythm control now. So we'll go ahead and use rate control. If it does not alleviate all your symptoms, if you're still left with symptoms, even though we hit your goals with rate control, a lot of time then we'll move to rhythm control to treat the rest of your symptoms that are left over. And if we still can't get your symptoms under control and your quality of life isn't where you want it to be, we can go into advanced therapies, and that's when you'd see a specialist like an electrophysiologist, and they can really figure out where this problem is coming to and make treatment goals to try to fix it, usually with procedures like the ablation or the maze procedure. Now, we'll talk a little bit about why anticoagulation is so important now. And then the reason why is because atrial fibrillation is the #1 cause of preventable stroke, okay? 1 in 5 strokes are caused by atrial fibrillation. And it increases your risk for stroke 5-fold compared to someone that doesn't have atrial fibrillation. And the strokes from atrial fibrillation are actually more severe compared to strokes that are not related to atrial fibrillation. They cause more disability, and they're much more dangerous. A gentleman asked, why is that? And it's tough to figure out, but a lot of time when a clot comes from your heart, travels up to your brain, it gets stuck in the blood vessel, and whatever blood vessel it gets stuck in your brain, it shuts off the blood supply to that part of your brain. And it can be a large part of your brain. And if it is the larger part of the brain or the different sections of your brain that the blood supply is cut off to causes the stroke symptoms. So these seems to be larger strokes. The infarcts in your brain, the part of the brain that is killed by these strokes are usually larger.
But why is that different than strokes caused by other?
Well, for example, maybe a stroke caused by a plaque doesn't cut off all the blood supply to the brain, and some of it's still getting through, or they're in smaller blood vessels than compared to the ones from atrial fibrillation. I've only got a few more minutes here, so we'll try to keep the questions to the end or during the question and answer questions, but thank you, absolutely. Now, this is the reason why I called it a preventable stroke, is because patients with atrial fibrillation that come into the hospital with a stroke, about 61% of them are on the most effective medication, warfarin. They're never put on it by their physicians, okay? And 29% of the patients don't have, their medication, warfarin, isn't working as well as it should be. Their INR isn't therapeutic, it's less than 2. And then about 10% of patients actually have INR in therapeutic range. Now, these are your risk factors. We can actually measure your risk factors for stroke. And you can see all the weak risk factors and the moderate risk factors and the high risk factors. And if you have no risk factors at all, a lot of times they'll say, okay, your risk for stroke isn't very big. We can treat that with aspirin. If you have one or more risk factors, then we have the choice kind of aspirin or warfarin. And if you don't have a large risk for bleeding, a lot of doctors will choose warfarin at that point. And if you have any high risk factor or more than one moderate risk factor, then we certainly need to use warfarin or one of the alternatives that Dr. Goldhaber talked about. And if you have any more questions about this, we'll go into the question and answer session with it, okay? Now, the reason why we can use aspirin for patients that are very low risk for stroke is because it decreases your risk for stroke by about 20% if we look at all the studies that they've done. But that doesn't compare to warfarin. When we put aspirin up against warfarin, then we get an additional 33% decrease in stroke, which is a huge jump. So a lot of times for patients that are higher risk for stroke, we use warfarin instead of aspirin. Now, the problem with warfarin is it has a very narrow therapeutic range, which means the dose that is perfect for you can be very close to the dose that's too little or too much. And you can see that in this picture. The therapeutic range for warfarin is 2 to 3. And that's because if you look at that green line, if you're below 2, the risk for ischemic stroke or blood clot, a stroke from a blood clot is way up. And if you're above 3, really above 4, the risk for intracranial hemorrhage, which is a bleed in your brain, starts to go up very steadily. So it's important that we stay in that range. Now, Dr. Goldhaber talked a lot about these, and so I'm just going to cover them very quickly. The two that have been approved for atrial fibrillation at this time is dabigatran, Pradaxa, and rivaroxaban, which is Xarelto. And they both reached what we call non-inferiority in their trials. In fact, dabigatran actually reached superiority, so it was better for stroke in a systemic embolism than warfarin. And non-inferiority, all that means is it's as good as warfarin, okay? And apixaban is still awaiting FDA approval. But we'll summarize the recommendations now. Atrial fibrillation is very common in older populations, and the prevalence is quickly increasing. The treatment strategies can include both rate or rhythm control, plus anticoagulation. You can even use a mix of rate and rhythm control. And it's associated with an increased risk of stroke, which we know. And the novel anticoagulants may offer stroke prophylaxis comparable to warfarin, and they have additional practical benefits of not having to test your blood and things like that. Well, that's a good question. A lot of times you'll walk into the pharmacy and you'll say, the pharmacist will say, why are you taking warfarin and aspirin at the same time? And he asks, how common is it for you to take both at the same time? And it's pretty common. Aspirin has an additional cardioprotective effect that is added to warfarin a lot when you have coronary heart disease, like if you've had a prior heart attack. But if you don't need both of the two together, aspirin and warfarin, if your cardiologist thinks that you only need one of them, it's important to only be on one of them. Because when you're on the two together, you have double the risk for a bleeding event than if you're on just one. There was a great study that showed that patients that coming to the emergency room with a stroke, how much, what's the difference between 1.8 and 2.0 and things of that nature. And he wanted us to talk about, what's the difference between being low, being high, what's your risk? And I would say being low can be a big risk with atrial fibrillation. If your INR is 1.8, you have twice the risk for having a stroke compared to someone with an INR of 2.0. And if your INR is 1.0, you're not taking it at all, you can have up to 18 times the risk of having a stroke compared to someone that has an INR of 2.0. And it depends on how many risk factors you have also, but that was what this one trial has showed of patients coming to the emergency department with a stroke. Okay, so the question was what to do with a missed dose of warfarin, and it's a great question. And this will be the last one. We'll bring the rest of the ones to the question and answer session. I think they're kicking me off the stage here. But what you want to do when you miss your dose of warfarin, the best way to figure out whether or not you missed it is to use a pill box, and use one that's separate from your other medications, because warfarin is different doses on different days. If your medication is still in the pill box from the night before, then you know you missed it. There's no question on whether I did or I didn't. If it's gone, you know you took it, and there's no chance that you're going to double up by accident. So the recommendation is if you miss it, skip it and wait to your next scheduled dose. And especially if you have a warfarin manager, you can call them the next day and say, I missed my dose. And we can help you make up for it, maybe take a little bit bigger dose the next night. But you don't want to take it in the morning. You want to wait until the next scheduled dose and give your warfarin manager a call. Okay. Thank you very much, guys. Please come with your questions to the question and answer session.